Welcome to this session on next generation sequencing for patients with advanced cancer. And in this session, we hope to summarize the 2024 recommendations of the ESMO Precision Medicine Working Group. Now, this working group recommendations were very recently published in Annals of Oncology um, uh, and sort of outlines the recommendations for use of next generation sequencing for advanced cancers, largely for tumor testing and also encompassing, in some cases, germline testing. And the basis for this recommendation is a systematic evaluation of evidence according to the SCAT. SCAT stands for the ESMO scale for clinical actionability of molecular targets. Now, to give a prelude to this 2024 recommendation, this is actually the second set of recommendations that have come up. The first set of recommendations from the Precision Medicine Working Group came up in 2020, which largely recommended NGS testing for five tumor classes. This includes the non-small cell lung cancer, the prostate, colorectal cancer, cholangiocarcinoma, and ovarian carcinoma. Um, while these were recommendations for these five classes of tumors, the ESMO 2020 recommendations emphasize that academic research centers should perform multi-gene next-generation sequencing as part of their mission to enable access to innovative new therapies for the patients. The 2020 recommendations also encompass tumor agnostic biomarkers, largely the tumor mutational burden for tumors of cervix, salivary gland, thyroid, and vulvar cancers, apart from endocrine tumors. So, that is broadly what is covered in the ESMO 2020 guidelines. In the 2024 guidelines, were largely based on the evidence encompassing the SCAT level 1 and at least in some cases the SCAT level 2 to facilitate patient enrollment in clinical trials and to also promote drug development in academic and research centers. While these recommendations encompass tumor classes, it should also be noted that these are not hard and fast rules. There is indeed a section on how these recommendations can be used outside the context, or in other words, clinicians could use NGS testing for tumors not recommended by the ESMO on some preconditions. The first precondition being that the patient is informed about the likely benefits, does not generate substantial extra cost to the patient or the system, and more importantly, it does not lead to off label use without adequate or sufficient evidence for action. The 2024 guidelines, in its present form, encompasses a number of tumor agnostic biomarkers much beyond tumor mutational burden, also encompassing MSI, and also encompasses the BRAF V600E, apart from three gene fusions, which includes the NTRK123, FGFR123, and the RET fusion mutations. Um, and this is in line with emerging evidence and approvals for these tumor agnostic biomarkers, now encompassing a variety of tumor classes. Now, the ESMO guidelines recommend multi-gene panels when in countries where such tumor agnostic therapies are accessible and available, and more importantly, only for patients with advanced cancers, and with the caveat that the clinician should ensure that fusions are indeed covered as part of the panel that is being prescribed for testing. Now, having said that, we need to quickly understand what are the kinds of fusion panels, what are the kinds of technologies for identifying fusions. Broadly, the fusion panels could be DNA based or RNA based. And even when they're DNA or RNA based, they could be based on a variety of applications or methodologies, including the hybrid capture, the amplicon based capture, or the multiplex anchored capture. Now, largely, the DNA based fusions could have some limitations that the partner, if not adequately covered by the fusion panel, may not be identified. But nevertheless, they're quite useful in very focused panels where they're very prevalent fusions which are widely used in clinical settings. But in many ways, the RNA panels, whether it's a hybrid capture panel or an anchored multiplex panel are quite very useful because they are partner independent. They enable partner independent identification of fusions, and therefore would add a lot of more value in identification and interpretation of fusions. Now, coming to the main guidelines, I stated before that the 2020 guidelines indeed recommended um, uh, tumor NGS testing for non small cell lung cancer in advanced cases. And this recommendation stands good, except for few reclassification of variants and evidence. And ESMO recommends that hospitals that run drug development or clinical trials should indeed run a multi-gene panel in the context of this recommendation. The second recommendation is for breast cancer. There's a new recommendation where it is recommended for HR positive and HER2 negative as standard of care. And the guideline states that to optimize the outcomes for ESR1 mutation, NGS testing is recommended after resistance to endocrine therapy. And there's also an additional recommendation regarding germline testing, where it recommends that in patients with a high likelihood of BRCA1 BRCA2 mutations should additionally undergo a germline testing, even as if it is negative for the tumor NGS. For colorectal cancer, multi-gene tumor panel is recommended according to the ESMO guidelines um, as routine practice. And it is recommended that if this does not add additional cost compared to the standard procedures such as IHC or PCR-based Sanger sequencing. The ESMO guidelines today also encompass prostate cancer uh, in the context of the approvals of PARP inhibitors, which are now available. And in countries where PARP inhibitors is available, India is one of those countries where there's indigenous manufacturing of PARP inhibitors. Tumor multigene NGS is sort of recommended. Uh, the ESMO guidelines also now encompass pancreatic ductal adenocarcinoma, largely in the context of PARP inhibitors and NRG inhibitors, which are now approved. And with a caveat or with a focus that when a clinician is prescribing an NGS panel for pancreatic ductal adenocarcinoma, a clinician should really look for whether the panel covers the NRG1 fusion, which is not a routine gene covered in most of the panels. And the recommendation also is in the context that an increased number of organ agnostic target therapies are now available. And if they're accessible to the patients, then the tumor NGS panel could actually offer quite a significant advantage. But what we need to keep in consideration is the cost effectiveness of the test and the treatment procedures. The interesting new update is in the area of ovarian cancers, where, of course, tumor NGS is recommended, apart from the addition of homologous recombination deficiency or the HRD testing. This is given the context of the approval of PARP inhibitors in HRD deficient cases. And there's also an additional recommendation regarding the germline testing, where it is recommended that if the DNA quantity or quality was suboptimal or the BRCA1 2 are not detectable, then they could be followed up, or the patient should be followed up with an additional germline testing for BRCA1 and BRCA2. Now, coming to HRD, now there are a variety of methodologies and tools which are widely used for HRD testing. And the ESMA guidelines actually provide an additional supplementary list of tests which are well validated. This includes the two FDA approved tests, which is from Myriad and the Foundation. And addition to that, a very recently published paper which uses the Ginkgo software, which is a Sophia DTM. And apart from an array based and two NGS based test, the last shallow HRD is based on a low pass whole genome sequencing and extensive computational validation. So this list could be quite useful for clinicians who are looking forward to using a validated HRT testing option. The major expansion in the ESMO 2024 guidelines is in the area of rare tumors, where a number of rare tumors have now been included as part of the recommendation. Some of them were included in the past, like, for example, the cholangiocarcinoma or the thyroid cancers. And what is included new is largely soft tissue sarcomas and the gastrointestinal stromal tumors, given the fact that additional NGS testing could afford a better molecular characterization of the tumor, and more importantly, the patients could avail many of the new and emerging targeted therapies, including the tissue agnostic targeted therapies. A new addition to the 2024 guideline is carcinoma of unknown primary, where the ESMO guidelines recommend use of NGS testing for two reasons: one, for targeted therapies, and more importantly, for the identification of the primary in cases of CUP, given the fact that very specific mutations can provide very useful clues on identifying the primary site of the tumor. The two tumors where ESMO does not recommend NGS testing, and one of it is hepatocellular carcinoma. But of course, this comes with an exception that tumor agnostic targeted therapies, when they're accessible, of course, these patients could avail NGS testing. And also with a caveat that immunotherapy is indicated in all advanced hepatocellular carcinoma, regardless of the genomic alterations or the genetic testing. And the second cancer is the gastric cancer, where ESMO does not recommend routine NGS testing as standard of care, but of course, with the exception as before in the case where targeted therapies are accessible and available. And in both the cases, ESMO sort of reiterates the fact that cost effectiveness should be assessed at the local level before the decisions of testing or not testing is recommended to the patient. The guidelines also cover quite useful insights into how to handle incidental results, largely in terms of incidental germline variants, in terms of secondary cancers, in terms of clonal hematopoiesis, especially in the context of hematological malignancies. My session this time is not going to cover these, but of course, we could cover this in a later part of the session. So, in gist or in summary, ESMO expands the tumor NGS recommendation to breast cancer, gastrointestinal stromal tumors, rare cancers, including the sarcoma, and apart from carcinoma of unknown primary or the CUP. ESMO recommends that tumor NGS testing for detecting tumor agnostic alterations and expands the menu of tumor agnostic or biomarkers that need to be tested, especially when therapies are available and accessible in the local context. And it reiterates the fact that tumor NGS testing should be performed in clinical research centers and may be discussed under specific circumstances with patients. Thank you very much, and I would love to take questions.